Welcome. I am Dr. Sujit Kumar Ghosh, Assistant Professor Cardiology. I welcome you in my class. Today's topic, sudden cardiac death. Here the definition you know everybody. Sudden cardiac death describes the unexpected natural death due to a cardiac cause within a short time period from the onset of symptoms in a person without any prior condition that would imminently fatal. That is, presence or absence of pre-existing cardiovascular disease is not necessary. We suspect sudden cardiac death if patient is symptomatic about chest pain, palpitation, dyspnea. These are suggestive of cardiac origin. So it is a guess. We can predict it might be a case of sudden cardiac death if patient have these symptoms. Usually time interval 1 hour or maybe less. Sudden cardiac death 80% occurs at home, 40% undiagnosed. Most commonly due to sustained ventricular tachycardia. That is influence of race, sex in sudden cardiac death. Sudden cardiac death increases in older sex due to atherosclerosis. সাধারণত senior persons, aged seniors in our society who are unattended, lacks care in the society, they face this consequence. 20% of sudden cardiac death occurs in less than 20 years. It is at young age. And the cause mainly due to structural cardiac abnormalities. That is hypertrophic obstructive cardiomyopathy, Brugada syndrome, congenital coronary abnormalities, that is left coronary, right coronary, origin from the different sinuses or pulmonary arteries, and arrhythmogenic right ventricular dysplasia. All these leads to fatal arrhythmia, leading to asystole and ultimate into brain death. These are the racial influence. More in black than white. Black per 1,000 men 5%, white 4.1% per 1,000 men. Asian is less, 2.1 per 1,000 men. Sex influence in sudden cardiac death. Here, men is greater than women. But without clear evidence of congenital heart disease, coronary heart disease, women are more victim than men. There are unnoticed cases, women suffer more due to valvular suffer more because there is lack of awareness about their cardiac symptoms and atypical presentation. But in known cases, most commonly, women suffer sudden cardiac death due to valvular cardiomyopathy, then coronary heart disease. Here you see the risk factors of sudden cardiac death: coronary heart disease, hypertension, hypercholesterolemia, smoking, diabetes. These risk factors basically similar to atherosclerosis. Ultimately, atherosclerosis is the prime pathology for sudden cardiac death in any situations except under 20 years, where structural cardiac heart disease is the main factor. But in young age, there is also ischemia is a provocative factor. There is no clear modifiable risk factors for sudden cardiac death, and it is not established yet. Novel markers are seen. If we consider, if we know some extraordinary risk factors for sudden cardiac death about hemostatic factor, inflammatory marker, polymorphism cardiac receptors. These will not only prevent the sudden cardiac death in aged person, but it will also help to detect, to prevent sudden cardiac death during other procedures like PCI, during MI, and other procedures. So, structural, electrical abnormality, and severity of clinical heart failure has practical importance. We can gauge about the fate of a person having structural abnormality, electrical abnormality, and severity of clinical heart failure in terms of left ventricular ejection fraction. We can predict about the outcome. Lifestyle factors are sudden cardiac death. Who are alcoholic, having cigarettes, lack of exercise, physically an important cause, and stress. Before some days, stress was not so much important, but now stress is very was emphasized because stress causes autonomic disturbance, which causes rupture of plaque, plaque, causes burst cardiac events. In young athlete less than 35 years, major cause sudden cardiac death, I have told you before, ACCM, coronary congenital coronary abnormalities, origin from deferred sinus of pulmonary artery. Less common are myocarditis, aortic dissection, aortic stenosis, maybe congenital, dilated cardiomyopathy, mitral valve loss. And there is confusion about mitral valve loss, but in case of young people, there is study and postmortem confirmation. Arrhythmogenic right ventricular contraction, cardiomyopathy, dysplasia. Here also occurs fatal arrhythmia, sudden cardiac death. Brugada syndrome causing young patient, death in young patient. Long QT, short QT. There are multiple factors causing long QT and short QT, causing polymorphic VT and sudden cardiac death. WPW syndrome, there is atrioventricular deemptive about contest of the TX section cause sudden cardiac death. And commercial bodies and typical time. It is a projectile, maybe blunt projectile, which causes sudden blow to the chest, and it interferes the electrical activity of the heart, causing VT, and ultimately leading to sudden cardiac death. It usually occurs in case of athletes or other situations, like any disturbance, blast, in these cases. Here you see the mechanisms of sudden cardiac death. Here you see the mechanisms of sudden cardiac death. These are you see substrate and triggers. I think this slide is very much important because all the pathology, these are explained by this picture. There are numerous causes of pathophysiology of sudden cardiac death, differential diagnosis, and all the substrates: hypertrophy, myocardial scar, atherosclerosis, coronary anomalies, myocarditis, infiltrative disease, bypass stents. We know about enzyme and substrate. Like biochemical reaction, which is arrhythmia can happen in this process. If patient has cardiac hypertrophy, left ventricular hypertrophy, or right ventricular hypertrophy, myocardial scar may be due to aging process or ischemia or inflammation or other cause. These are also good structure. Atherosclerosis is ultimately main cause. Coronary anomalies, myocarditis, infiltrative bypass stents. When these structural changes faces autonomic changes, that is increased sympathetic activity, they are really SARS. or decreased parasympathetic effect that is ultimately abnormal overdose, electrolyte abnormalities, physical exertion, mental stress, and drugs. When substance faces these situations, then there occurs electrolyte shifts, electrical instability, platelet degradation, vasoconstriction, and ischemia, leading to these cardiac arrests, VT, VA, asystole, electromechanical resuscitation. Cardiac arrest, two types: shockable, non-shockable. VT and VA, shockable. Asystole, electromechanical resuscitation, non-shockable. And which causes impairment of mechanical contraction, cessation of mechanical contraction of the heart, cerebral blood flow reduced, brain death, and ultimately loss of life. Here now we will go next. In this slide, I have shown you the whole cardiology. In fact, ischemic heart disease, non-ischemic heart disease, you see the causes, numerous causes. I cannot recollect, but all the pathologies ultimately, when substrate there is substrate in this pathology, here occurs of autonomic disturbance, fluid shift, drugs, all the triggering factors leading to sudden cardiac death. Here you see coronary atherosclerosis, acute myocardial infarction, chronic ischemic cardiomyopathy, anomalous origin of coronary disease. How anomalous origin of coronary arteries causes sudden cardiac death? In case of anomalous origin of coronary arteries, if left coronary artery originates from the right aortic sinus or right coronary artery originates from the left aortic sinus, there is split-like hypopnea. In stress or in sudden physical exertion, there is impairment of flow through the coronary ostium, which causes supply-demand mismatch and leading to fatal arrhythmia and cardiac death. Hypoplastic coronary arteries, same cause, supply-demand mismatch, arrhythmia, cardiac death. Coronary artery spasm, same cause, supply-demand mismatch, coronary artery spasm, supply-demand mismatch, tachyarrhythmia leading to cardiac death. Coronary artery dissection, impairment of the flow due to false lumen, ultimately leading to tachyarrhythmia and cardiac death. Coronary arteries here occurs in case of connective tissue disorders like ASLE, polyarteritis nodosa, and nowadays in corona situations, Kawasaki disease, in case of younger patients, causing ultimately impairment of the coronary flow and cardiac death. Small vessel disease, so these are the possibilities from ischemia due to ischemia. But here there is a misnomer. Non-ischemic cardiac heart disease, there is cardiomyopathy, intellectual inflammatory disease, valvular heart disease, congenital heart disease, primary electrical abnormalities, drug-induced electrolyte abnormalities. In case of cardiomyopathy, infiltrative, valvular heart disease, silently there is a role of ischemia. All these situations, when there is a ischemic trigger, this can lead to tachyarrhythmia and cardiac, such as idiopathic dilated cardiomyopathy, hypertrophic cardiomyopathy, hypertensive cardiomyopathy. Autonomic disturbance can lead to these cardiomyopathic situations in a state of tachyarrhythmia, ultimately leading to asystole and cardiac death. So, infiltrative and inflammatory disease, sarcoidosis, amyloidosis, myocarditis, these in these situations, there is a re-entry triggered activity and leading to tachyarrhythmia and cardiac death. Valvular heart disease, aortic stenosis, aortic regurgitation, mitral valve collapse, infective endocarditis. In aortic stenosis, I have shown you that there is a substrate hypertrophy, aortic stenosis left ventricular hypertrophy. So, this causes tachyarrhythmia and sometimes sudden cardiac death. Long-standing hypertrophy in case of aortic stenosis and aortic regurgitation causes fibrosis, ischemia, relative ischemia, which causes DNT, and if there is any electrical involvement and or other triggering factors leading to, even in case of ischemia, leading to tachyarrhythmia and cardiac death. In case of mitral valve collapse, mitral valve commonly occurs in case of female. Commonly occurs in case of mitral valve, in mitral valve collapse, there occurs MR, mitral regurgitation. When this increases, there occurs left ventricular dilatation as well as left ventricular hypertrophy. And sudden, occasional, this valve myxomatous degenerates and leading to acute humor. In acute humor, there occurs sudden heart failure, arrhythmias, and cardiac death. On infective endocarditis, there is something different, especially in case of aortic valve, aortic regurgitation, aortic valve infective endocarditis. If there is vegetations, these vegetations dislodges and enters into the coronary artery, leading to MI, arrhythmia, heart failure, cerebral. So, coronary embolism is the causing sudden cardiac death in infective endocarditis. Congenital heart disease, that is tetralogy of Fallot. I have told it, please recollect substrate. Tetralogy of right ventricular hypertrophy. It's a substrate. When ischemia acts on it, electrolyte imbalance, sudden autonomic disturbance acts on it, leading to tachyarrhythmias and cardiac death. Same in case of transposition of blood vessels or after correction, same, all the same. If anomaly, there is a huge left atrium and associated occasionally associated with WW syndrome and bypass state, leading to fatal arrhythmias and cardiac death. Pulmonary vascular obstructive disease ultimately leads to right ventricular hypertrophy, tachyarrhythmia, and cardiac death. We know these patients that it should be corrected earlier. Otherwise, hypertrophy may be right ventricular or left ventricular, leading to there is a substrate for ischemia, autonomic disturbance, arrhythmia, heart failure, and ultimately the fatal outcome. Congenital aortic stenosis causes hypertrophy left ventricle, ultimately leading to sudden cardiac death. Now, primary electrical abnormalities. There is long QT syndrome, short QT syndrome. Long QT syndrome, long occurs in hypokalemia, hypocalcemia. In these cases, it occurs long QT syndrome. Long QT syndrome, ultimately, if there is patient has bradycardia and there is a PVC, this causes prosthetic depointis, and it's it's a very fatal arrhythmia, and leading to ventricular fibrillation, sudden cardiac death, systole and sudden cardiac death. WPW syndrome, I have told you earlier, it causes pre-excitation syndrome, broad complex tachycardia, if there is atrial fibrillation. And as there is a bypass tract in case of WPW syndrome, there is no filtering effect of AV node. There is no filtering effect of AV node. So, pre-excitation syndrome leads to very rapid deterioration and rapid tachyarrhythmia, cardiovascular collapse, leading to sudden death. Congenital AV block. This is a atrioventricular block. The patient of SLE give birth on sometimes congenital complete heart block. If congenital complete heart block has no rate response during physical exercise, chronotropic. If congenital AV block, that is congenital complete heart block, lacking chronotropic incompetency. Sometimes near the bundle of his, very close to bundle of his, if complete heart block shows chronotropic competency. That is, heart rate increases during physical exercise. But in some cases, the complete heart block position, the exact location of the complete heart block far beyond the AV node, and bundle of his leading to white complex QRS. This lacks the chronotropic competency, and leading to systole and sudden cardiac death. Brugada syndrome, congenital abnormality, channelopathy. It also known as myopathy, also Brugada syndrome, sodium channel abnormality. And in this situation, young patient having electrolyte disturbance, such as exertion, sweating, diarrhea, liquidation, leading to prosthetic depointis tachycardia, ultimately ventricular fibrillation and sudden cardiac death. catecholinergic polymorphic BT. Here is also congenital cessation. Here increased physical stress or psychological trauma leads to ventricular tachycardia, ventricular fibrillation, degenerative system, secondary death. Idiopathic cause I can guess, in fact, ventricular fibrillation leading to system cardiac. Early repolation variants before 40 years, early repolation can be known, but after 40 years, if there is an early repolation, it should be emphasized and ischemia should be excluded um, to uh, to prevent some cardiac death. Drug-induced and other toxic agents, you see anti-arrhythmic drugs, say class 1A, 1C, and 3. It is also a bidirectional activity, these anti-arrhythmic drugs. 1A, 1C, 3. These are also used to control the tachyarrhythmia like BT, lidocaine, amiodarone. But if there is multiple triggers, like ischemia, electrolyte imbalance, these can rebound the arrhythmia, ultimately leading to some erythromycin, clarithromycin, methadone, most commonly these causes prolonged leading to torsades de pointis and some. But if see cocaine, cocaine causes extensive vasoconstriction, leading to MI and some cardiac death. Chloroquine by increasing torsades de pointis, alcohol, phosphodiesterase inhibitors, MNFL, ultimately leads to tachycardia. In case of organophosphates, causes sudden cardiac death. It's not very common, but I have found cases in my hospital in health complex practice. Electropinized patient, sudden death. It happens. Now electrolyte abnormalities, hypokalemia, hypomagnesia, hypoglycemia, all leads to increased QTC, ultimately leading to torsades de pointis and sudden death. Anorexia nervosa, bulimia, liquid protein dieting, diuretics, all ultimately causing electrolyte imbalance and leading to if there is substrate like hypertrophy, scar, and others, this causes some cardiac death. So, extensive diuretic therapy should be warned for a prolonged period of time. I'll go to the next slide. I have told earlier that less than 35 years and more than 35 years. Less than 35 years, hypertrophic cardiomyopathy is the main cause of some cardiac death. And the other cause, coronary heart disease, unexplained 3% ruptured aorta, coronary anomalies, idiopathic left ventricular hypertrophy. And more than 35 years is coronary heart disease, that is atherosclerosis, and then you see 80%. যত sudden cardiac death আছে, young, non-young, every cases, we have to exclude ischemia first. We have to exclude them as well as other main pathologies. If there is any scope for the patient to face ischemia, which can lead to fatal arrhythmia and some cardiac death. And the other causes, except coronary heart disease, we see hypertrophic cardiomyopathy, valvular heart disease, mitral valve collapse. It's 5% unexplained. Clinical presentation, you see you perform your duty in CC1. There's lots of patient blood death. Patients are most commonly found ventricular arrhythmia, VTVF, CPR দিতে patient অনেক মরে যায়। কিছু দেওয়া যায় না CPR. If patient have fibrillatory rhythm, VT or VF, I have told you two types of cardiac arrest: shockable, non-shockable. VT, VF, shockable, non-shockable, assisted pulseless electrical activity. So, if there is shockable cardiac event, we put the patient near the monitor, take consent of the patient, and give defibrillation. So, and I have told you the defibrillation severe advance. It is your everyday activity, so you know it very better than me. Survival and prognosis after cardiac arrest. Factor associated with increased hospital mortality. We face cardiac arrest patients on regular basis. And sometimes we can found a positive outcome and sometimes negative outcome, but which predicts about the negative outcome. If the patient's presentation with cardiogenic shock or after defibrillation, there is no pulse blood pressure. If patient is more than 60 years or needs more shock, other than myocardial infarction, that is, myocardial infarction is a treatable cause. If we revascularization by thrombolytics or PCI, there is a very, very good recovery. But if we cannot do this, there is congenital anomaly, so there is fatal arrhythmia and mortality. If patient has come on hospital admission, that is, he has a damage to the central nervous system, and you see that during defibrillation, VT responds better than VF. If VF response, outcome not so good, and there is the more fatal is pulseless electrical activity. If you carefully look about pulseless electrical activity in a system, you will find that from the history of the patient that the patient had previous long-standing heart disease. If patient left ventricular functional impairment, maybe congestive heart failure. So, pulseless electrical activity of most culprit arrhythmias, which are difficult to face and which is very much difficult to respond in our normal daily practice. In this case, if when there is a left ventricular impairment too much, in case of pulseless electrical activity or asystole or like bradyarrhythmia, if you do TPM and other inotrops and most combined treatment, do not respond too much, and patients ultimately lead to severe comorbidity or sudden cardiac death. Now, in case of 40% patients of cardiac arrest facing defibrillations and other rescue therapy, we get 14% patients which reaches our hospital, we can discharge them. Among 100%, we can 14% patients can discharge with a good recovery. So we have lots of things to do about cardiac arrest survivors and risk stratification. If we can rescue a patient cardiac arrest and proper risk stratification can be done and the necessary intervention can be done, patient can lead a good life, it's a healthy life, more optimum activity, optimum physical activity. And the most striking effort should be given during admission from the shock decision to CC1, the time we spent in CC1, that is correction of electrolyte imbalance, correction of coronary ischemic issues, better actually. Here electrolyte imbalance means hypokalemia is the prime importance, hyponatremia and other, but hypokalemia is much important. আমরা যারা ইসিসিতে যাই, সারা একটা ইসিসি দেখি বলে ইসিসিতে কি আছে, ইলেকট্রোলাইট কি আছে, মেটাবলিক কি আছে. So hypokalemia, when there is a destruction of the myocardial fibers, when there is destruction of the myocardial fibers, myocardial injury, potassium in the cell comes out and sodium enters into the activity. This causes shortening of that action potential, but firing too much. There is a short action potential. There is a sudden stoppage of slow sodium potassium current, sodium calcium current surrounding conduction abnormalities, which can lead to bradyarrhythmia, and EDMT, which can lead to tachyarrhythmia. And the consequence of arrhythmia, more cardiac instability, more insult, not only in cardiac, coronary arteries, heart, or more insult to the brain, kidney, and multiple vital organs. And this causes sometimes an irreversible condition. So, first, we should establish a good cardiac rhythm, patient's hemodynamic status improvement, correction of electrolyte and imbalance in metabolic parameters like CVD, renal failures, and good treatment about this. If there is ischemia, anemia correction, we can expect a post-cardiac arrest patient in a better outcome. You just you know everything. You know everything. You know everything. We have not seen about therapeutic hypothermia, but in improved centers, hypothermia causes optimum neurological recovery because metabolism. Here, in case of hypothermia, metabolic activity of the cells become optimum. If you know, the basic treatment is rest and fasting. So in this situation, we can lead to increased amount of ATP. The heart can cope with the need. But if there is increased metabolic activity, your heart will face a subdimensional mismatch and will collapse. And now the checklist for history, physical evaluation, ECG, these are all done to assign to assess the substrate and ultimately triggering factors. Slides before. The ECG biomarkers equals stress in cardiac and bicardiac condition. In our hospital, here biomarkers echo frequently done, and we do assess from biomarkers and the extent of damage and the function of impairment. And this for the further planning of the management of the patient. In case of stable patient, how can we risk how can I stratify the risk percentage? From clinical history, in case of structural heart disease, we saw family history, left ventricular family history, and other surrounding history, and left ventricular dysfunction we do electrocardiographic abnormalities, that is, we like Dogoracinum and others. We have WPW, congenital, MI, and we can see this from this ECG. Autonomic markers that most commonly serum troponin, and the others biomarkers we can high sensitive come in our practice. And signal average ECG. Signal average ECG are the late potentials. That is, in case of QRS complex, late 40 milliseconds, there is the increased amplitude of the ECG, which is very much representative of clinical ischemia. And if this if this abnormality happens in ECG, normally it can be guessed, but it should be calculated from 200 to 400 ECG calculation from different applications. Not frequently practiced in our hospital, but signal average ECG, if there is increased amplitude in the leg potentials, these lead to fatal arrhythmia in case of increased physical exercise or physical stress leading to fatal arrhythmia, tachyarrhythmia, microscopic clear ultrasound. In case of QT interval, prolonged QT intervals. In these patients, congenital prolonged QT interval, that is, question it is more than 500 milliseconds. So, in that cases, if there is physical exertion or physical exertion, we can see macroscopic tube alternate beats. This patient can give you warning that this patient can lead to ventricular tachycardia, ventricular fibrillation, and ultimately leading to assisted cardiac death. In case of epistudy, advanced procedure not frequently done. In case of epistudy, if there is family history of sudden cardiac death, epistudy can be patient repeatedly getting DC shock. You can study, you can detect the tachyarrhythmia like monomorphic VT and the actual site of origin. And here, in that cases, we can have a plan about the control of the VT, like ablations and other procedures to drugs, appropriate drugs, to select appropriate drugs. If study can be done, but it is very less to practice in our hospital. Drug therapy for prevention of sudden cardiac death, you see, beta blocker, AC inhibitor, statins. I have started these three plus antiplatelet steroid. I have trust. But class 1 antiarrhythmic agent, I have shown you 1A, 1C, and sotalol. These are class 3. Can lead to control of tachyarrhythmia. On the other hand, this can lead to complete arrhythmia. So these can also cause sudden cardiac death. But during the emergency situation, we have the options. In case of amiodarone, class 1 sotalol, I have not practiced too much, but in case of amiodarone, if there is cardiac functional impairment, ejection fraction less than 35%. The other drugs where lidocaine cannot be given, and arrhythmia, amiodarone plus inotrol. If we combine practice to tackle a tachyarrhythmia, we have seen a better outcome. So amiodarone for short time to control arrhythmia, amiodarone is a very good one. And when patient becomes stable hemodynamically, we shift from amiodarone to beta blockers. And our teachers like to hear about old teachers, those of amiodarone, oral, IV, and how do you shift. And so amiodarone is a very much important drug in every emergency situation, in both ventricular and supraventricular arrhythmia. Now, device therapy for prevention of sudden cardiac death. I have classified this device therapy in very short. You will know our teachers from EP studies. Will know more. Device therapy, I know that is ICD, defibrillators, and CRT. ICD usually patient ejection fraction more than 35%, and patients congenital abnormalities leading to tachyarrhythmia in their cases can primarily used. And CRT, left ventricular impairment, there is desynchrony, then CRT used. So functionally less severe. In that case, patient having significant arrhythmia, ventricular arrhythmia, we usually our choice ICD. But if there is functional impairment, severe functional impairment, there is asynchronization. Heart failure functional impairment is more. That is any heart failure is class 3, class 4. In that case, CRT is needed. You see here, there is two trials. That is MEDIT, must. in your exam, these two trials, if you can tell about these two trials, that from these two trials, ICD therapy is superior to amiodarone. The examiner will be happy, and they will guess that patient, the student will know about the latest device therapy, like ICD situations where these can be given. In SCD aseptic trial, a median 45 months of all-cause mortality, you see ICD, amiodarone placebo. A reduction of cardiac death, 22% in case of ICD, 28% in case of amiodarone, and 29% respectively. ICD also used in conditions, as I have told you earlier, ASCM, long QT syndrome, Bogata syndrome, having right ventricular contraction. But practical use of this ICD in this situation not very practiced in our country. So, I have told you earlier that with that beta blocker, antiplatelet, AC inhibitor, the quadruple is to prevent the ischemic insult. I expect that if this patient has a good lifestyle and if we prevent the ischemic insult, this will not develop tachyarrhythmia and then risk of the sudden cardiac death will be diminished. And last one, I have shown you that ICD is not used in NICVD type 4 because in case of ICD, it can sense the rhythm, defibrillate the rhythm, and pace the rhythm. But in case of severe heart failure, that is LVEF, reduction of left ventricular ejection fraction less than 30%, 35%, that is not enough for the patient to achieve a good hemodynamic status. Here needs synchronization. As synchronization is needed, here is CRT is needed. And the CRT, you know that we have around in your respective ward criteria for CRT, you know that if patient is LVVB, patient is sinus rhythm, QRS complex more than 130 millisecond, ejection fraction less than 35%, and there is asynchrony in the echocardiography. In that patient, most likely extreme cases, in extreme cases we can give CRT. But in case of CRT, if you put a patient on CRT, patient needs some myocardium to produce good hemodynamic status. If there is severe fibrosis, there is no improvement in good hemodynamic status by CRT. In these situations, lots of CRT are given in advanced countries, but there is a study that less than 70%, less than 30%, more than 30% do not have produced the desired effect. More than 30%, that is 70% CRT can give you a good hemodynamic status, which prevents the cerebral death. And you see the role of surgery to prevent the sudden cardiac death. Here, a number one revascularization. We do very much revascularization in this. Ashtli আমরা চেষ্টা করি যে তাকে অ্যাঞ্জিওগ্রাম করে কিছু একটা করা যায় কিনা। But PCI confusing. But CABG in books, CABG as a is to prevent the sudden cardiac death than PCI. So in case of MI patient or post-MI patient, we can do primary or elective PCI. So if we revascularize the patient, there is improvement of the cardiac status and left ventricular function status, which can reduce the incidence of sudden cardiac death. And antiarrhythmia surgery here, this occurs in case of ACCM and other situation, which causes the submucosal endocardial resection of the culprit myocardium, reduces the incidence. But not a practice nowadays in our country, and I have not seen this. Catheter ablation therapy, by study, we can locate the site of the entry for ventricular tachycardia. Then we can ablate the site and that can prevent the sudden cardiac death. Now you see, in Brown world, there is no chapter about sudden, not only chapter for sudden cardiac death plus cardiac arrest. And so I have shown you that there is a basic life support protocol. You do this protocol every day. Patient comes shouting, conscious, unconscious, breathing or not, responsive or not, monitor attached to the monitor, shockable rhythm or non-shockable rhythm, and if there is response, we start CPR. And these are in daily practice. And the basic life support protocol, you see that ultimately CPR, advanced life support protocol, shock, start with adrenaline, and now see adrenaline. Now see advanced life support protocol, see CPR start kori, BTPF, shockable rhythm, assistol, pulseless electrical activity. Shockable rhythm আমরা ডিসি দেই, CPR দেই, ডিসি দেওয়ার পরে পেশেন্টের রিদম চেক করি, রিদম চেক করার পরে আমরা দেখি পেশেন্ট যদি রেসপন্সিভ হয়, ওকে, তাকে আমরা সাপোর্টিভ ট্রিটমেন্ট আদার অ্যান্টি থেরাপি দিই আমরা, এবং পেশেন্টকে আমরা পেশেন্ট যদি তখন স্যাচুরেশন না ফল করে তাকে আমরা ইন্টিউবেট করি, অনেক সময় ইন্টিউবেট করে অ্যাভয়েড করি। বাট ইন কেস অফ অ্যাসিস্টল পালস ইলেকট্রিক্যাল অ্যাক্টিভিটি, সিপিআর ইজ দ্য সিপিআর। এই অ্যাসিস্টল পালস ইলেকট্রিক্যাল অ্যাক্টিভিটি is the fatal, because in these patients we can take history that patients have left ventricular functional impairment for long days, even patient counts with CCF. These rhythms not too much responsive, so outcome is not very much satisfactory. We see that we also treat hypoxia, hypocalcemia, electrolyte imbalance, hypothermia, thrombosis, 4H, 4HT, most followed in case of pulseless electrical activity. Now, third part, there is a Viva question, written question. You see some important questions here, that is indication of ICT, indication of CRT, signals about STM microscopic durable runs. I have added this slide because these are the very much common short note, which appears in every third part written exam. This is my last slide. ব্যক্তিগতভাবে আমি মনে করি সাডেন কার্ডিয়াক ডেথ মানে পুরো কার্ডিওলজি। আপনারা যদি এই চারটার দিকে তাকান, দেখবেন যে এর মধ্যে সব ধরনের প্যাথোলজি আছে, আর সব ধরনের ট্রিটমেন্টই, কার্ডিয়াক সব ধরনের ট্রিটমেন্টই করা যায়। ধীরে ধীরে আলটিমেটলি আপনারা পড়বেন এবং প্রতিটা চ্যাপ্টারই আলটিমেটলি দেখেন এর সাথে রিলেটেড আছে। সুতরাং আমাদের কাছে যদি একটা পেশেন্ট আসে, if we feel that is a case of cardiac case, আমাদের কাছে একটা, আমার মনে হয় আমার প্রথমে মনে করতে হবে যে এর জন্য সাডেন কার্ডিয়াক ডেথ না হয়, এবং এর জন্য যা করা দরকার আমাকে I have to do that. So thank you for patient sharing. If any questions, please. Hello. এই কোশ্চেন আছে নাকি? কানেকশন লস হয়েছে?
না স্যার, আছে স্যার।
আচ্ছা, তাহলে তো আমি তো শেষ করলাম। আপনাদের যদি কোশ্চেন থাকে কিছু বলেন।
স্যার, আসসালামু আলাইকুম স্যার।
ওয়ালাইকুম আসসালাম।
স্যার, থ্যাংক ইউ স্যার ফর ইওর নাইস প্রেজেন্টেশন স্যার। স্যার, ডেফিনিশন অফ সাডেন কার্ডিয়াক ডেথ যদি বলা হয় তাহলে কি আমরা উইদিন 1 আওয়ার যেটা ওইটা বলবো স্যার?
এইটা দুই বইয়ে দুইটা আছে, তবে স্যাররা এটাই মানে অনেক আগে থেকে এটাই প্রচলিত। এটা শুনলেই স্যাররা মানে কোয়েরি করে না। এটা অনেক আগে থেকে প্রচলিত উইদিন 1 আওয়ার, কারণ ফিমেলে অনেক সময় নোটিশ থাকে, বলাই তো আছে 80% বাসায় হয় এবং 40% মোর দেন 60 ইয়ার্স পেশেন্ট নেগলেক্টেড থাকে। আমাদের কাছে তো নিয়ে আসে, আমরা লিখে দিই ব্রড ডেট। তো ব্রড ডেট আলটিমেটলি সবই কি প্যাথোলজিক্যাল, সবই কি খুন হয়েছে? আলটিমেটলি sudden cardiac death. It's a natural death. It's a thing, unexpected natural death. It's a natural death, but unexpected. But unexpected, unnatural death. Ultimately, postmortem examination. It's an unexpected natural death. Surrounding clinical situation যদি মনে হয় যে ultimately যে there is no homicidal or other clues, then it's a sudden cardiac death.
স্যার আরেকটা কোশ্চেন ছিল যে স্যার আমাদের ওই যে হাস্টের মধ্যে দেওয়া আছে স্যার,
এটা হাস্ট
কজ অফ সাডেন কার্ডিয়াক ডেথের এখানে হচ্ছে যে অ্যাথলেটস বা এজ গ্রুপ স্যার আপনি দেখাইছিলেন স্যার, ওখানে লেস দেন 35 মোর দেন 35 এখানে মনে একটু ভুল আছে স্যার।
হ্যাঁ, ওই হাস্টের ছবিটা একটু সমস্যা আছে, ওটা একটু কারেক্ট করে দেখাচ্ছি।
জি স্যার, তাহলে প্রথমটা হবে লেস দেন 35 স্যার।
হ্যাঁ হ্যাঁ, বলুন লেস দেন 35। হাইপারট্রফিক কার্ডিওমায়োপ্যাথি যেটা লেস দেন 35
এটা স্যার।
আর এটা হলো এটা একটু ভুল আছে ছবিটা, আমি এটা কারেক্ট করতে পারি না, এটা উল্টা পাল্টা হয়ে গেছে। এটা হলো লেস দেন 35, এটা হলো মোর দেন 35।
জি স্যার।
তাহলে শেষ করে দিব, আর কোশ্চেন নাই? হ্যালো
স্যার,
জি
কারো কোশ্চেন আর আছে কিনা স্যার
দেখেন, স্টপ করে দিব। Okay, stop. Thank you.
থ্যাংক ইউ স্যার।
Okay.
Thank you, sir.